Hello and welcome. My name is Dr. Jack West, and I'm a medical oncologist in Seattle, Washington, and also the president and CEO of GRACE, the global resource for advancing cancer education. Today, we're doing a program on lung cancer highlights from ASCO, the annual conference of the American Society for Clinical Oncology, held in June of every year. This live webinar, as well as the podcast materials to be produced from it, are the product of a partnership between GRACE and the Longevity Foundation. Let's move to the second half of the program, and this will focus on the metastatic advanced non-small cell setting where there was a lot of activity. And Dr. Nasser Hanna is Associate Professor of Medical Oncology and a particular expert in thoracic oncology, lung cancer, and mesothelioma. With that, I'll turn it over to him.
Well, thank you, Jack, and I really appreciate having the opportunity to participate in tonight's webinar. I'd like to go over metastatic non-small cell lung cancer. I'm going to highlight just a handful of studies over the next 15 to 20 minutes. And these are my disclosures. I always have a hard time knowing exactly what to say, and here I actually don't think I have any conflict of interest, but I never quite know, so I just sort of list things that I'm not sure about. So there you go. Okay, so this is my overview slide. I think the most exciting thing I'm going to talk about today are the first two presentations, which is ALK inhibition, which is a true breakthrough. This is a really big deal and a major discovery in lung cancer that will have an impact on tens of thousands of people's lives. Mark Chris presented an elegant presentation on driver mutations, which I think is going to set up the big breakthroughs in the next 5 to 10 years. And then I'm going to talk about a new target, MET. And then I'm going to just review very briefly 3 abstracts looking at more refining strategies with existing tools rather than really new agents or new targets. So I'm going to start with the most exciting data, and that's with crizotinib. So at the plenary session of ASCO in 2010, this phase 1, phase 2 study was presented. It's been published in the New England Journal of Medicine, and crizotinib was assessed in the classic phase 1 study. Once the phase 1 dose and toxicities were best defined, the patients who had ALK-positive tumors and the patients who had MET-positive tumors were then enrolled on separate clinical trials with crizotinib. So this trial looked at patients with non-small cell lung cancer who were positive for the ALK gene rearrangement as tested by FISH. They had 1,500 patients that they screened, and they identified 82 eligible patients. And these patients were all positive by fluorescence in situ hybridization. There were 2 other methods for which you could test for this ALK gene. One is polymerase chain reaction, and 31 of those patients were tested. 9 of the 31 actually were negative for finding an ALK partner. So it was not the way that patients were screened, but it was an important observation. 25 patients who were tested who were FISH positive were all positive by immunohistochemistry as well. This is a very heavily pretreated patient population. Most of the patients that had 2 or 3 or 4 prior regimens, and they were given crizotinib, and they were all ALK positive by FISH. The typical response rate in this patient population would be expected to be about 5%, with about 15 to 20% of patients with brief stable disease, with a whole number of available regimens. But amazingly, 57% of the patients achieved an objective response. An additional 33% of patients achieved stable disease. So at ASCO this year, Dr. Camage updated this data and reported progression-free survival of this phase 1 study with 119 patients. And these were the characteristics of these 119 patients. Half were men and half were women. 72% of the patients were never smokers. But it's important to note that 28% of the patients were former or current smokers. It really had been previously thought that ALK gene rearrangements were seen almost exclusively in never smokers, but that's clearly not true. 28% of patients in this series were former or current smokers. Almost all of the patients on this trial had adenocarcinoma, and as you can see, the majority of patients had received multiple prior therapeutic regimens. Despite that heavily pretreated group of patients, the response rate for the 116 patients for whom it was evaluable was 61%, and 31% of patients had stable disease. And this is really remarkable. 92% of the patients given this single-agent oral medicine had control or response in their disease. And the response was much longer than one would expect with chemotherapy agents. The median duration of response was almost a year, meaning half of the patients actually responded far greater than a year. And the responses were quick. These patients knew it soon. The first disease evaluation, they had found a response. And the progression-free survival, which in these trials is typically 1 to 3 months, the median was 10 months on this trial. The overall survival of the median had not been reached at the time of this report, but 81% of the patients were alive at 1 year. And again, if you look at historical controls with many agents, this number would be expected to be more like 20 to 25%. There were some adverse events, and one of the more unique ones is this visual field effect that the patients experience. It's like a stream of lights that they see, sort of like the effect that you have when you're staring at a light bulb and then suddenly you turn the lights off and you kind of move your head to the left and the right and the light sort of streams left and right. And it's kind of an interesting side effect that most patients get. It's thought to be due to the fact that ALK is important in the development of the circuitry of the visual system. There is a little bit of nausea and vomiting, generally grade 1 and grade 2 with this drug, and that's because ALK is thought to be important in the development of the gut as well. So there were a few comments that I had other than the fact that this is really a big deal and a remarkably active drug. The authors were not able to provide us any information on various fusion subsets. We know that EML4 ALK is the most common fusion partner with ALK, EML4, but there are other partners. There are several variants of EML4 that partner with ALK, and we know preclinically that they have variable responses to ALK inhibitors. So there is more room to refine this information. We know preclinically that ALK inhibitors are more active than chemotherapy in patients who have ALK-positive disease, and retrospective data does appear to support this as well. There was some recent interesting data that suggested that pemetrexed is also quite active in patients who have an ALK gene rearrangement, but ultimately the company has recently completed a phase 3 study. This is a second or third line trial, patients who have ALK gene rearrangements randomized to either docetaxel or pemetrexed versus receiving crizotinib, and hopefully we'll get the answer to that trial this year. Now, I'd like to move on to a very important presentation that Mark Chris provided on behalf of a new organization called the Lung Cancer Mutation Consortium, and this is a group of investigators who received federal money to help train their individual pathology labs to run molecular profiling on patients with adenocarcinoma in their institutions. So the objective was to take 1,000 tumor samples from patients with adenocarcinoma, and they assessed them for what we call druggable targets. In other words, mutations that can be found for which there are available drugs, either on clinical trials or commercially available, that could be used to treat patients. And these are listed on the slide, and this did include EML4 ALK, EGFR, and the others listed here. Ultimately, they wanted to use this information to try to figure out what clinical trial to place these patients on. Many of these institutions had phase 1 studies, for instance, with MEK inhibitors. And so if you had a MEK mutation identified in this series, you would be preferentially placed on that clinical trial. So this was the overall design. They took 1,000 patients who had stage 4 disease with adenocarcinoma, and of course they had to have sufficient tissue for testing. This was confirmed in a central lab to be adenocarcinoma. Then they did the mutational analysis testing in CLIA-certified labs at 14 different institutions. That information was reported to a database in a virtual way so they can each see them, and also reported to the individual physicians. If patients were found to have EGFR mutations, they were treated with erlotinib. If they were found to have other targets, they were then routed towards individual clinical trials. And this is the really important slide here. This is the entire population of patients for which they've tested thus far, which is 516 patients. More than half of the patients were found to have a druggable gene mutation, 54%. The majority of those were patients who had KRAS mutations, 17% had EGFR mutations, 7% had the EML4 ALK gene rearrangement, which is the target for crizotinib. But you can see there were a variety of other targets which by themselves were not in large numbers, but when you add them up, you'll find that the majority of patients had at least one target that could be looked at. When you had a target, you usually had no other targets. So 97% of all the mutations that were discovered were mutually exclusive. So if you had an ALK gene rearrangement, you really didn't appear to have any other hits in EGFR or KRAS and so forth. This was occasionally not true, but again, only 3% of patients had more than one gene mutation found. That's 14 out of 516 patients. So I really think that that type of data, which has been generated by this lung cancer mutation group and is being generated by other groups such as the one at MD Anderson, is really building the backbone of how we're going to treat our patients in the future and how we're going to select clinical trials for our patients. Now, Dr. Spiegel looked at a new class of agents called MET inhibitors, and he reported the final results of a randomized phase 2 study of a drug called METMAB in combination with erlotinib versus placebo in combination with erlotinib. And this is the background with METMAB. MET is apparently an important target in non-small cell lung cancer. By itself, it's implicated in driving the growth of some cancers, but it also appears to be a mechanism of resistance to EGFR inhibitor activating mutations, such as there are a group of patients who have EGFR mutations who respond very well to erlotinib and then eventually develop resistance. When those patients have their tumors rebiopsied, about a third of them have MET amplification, which appears to be the mechanism of resistance for either erlotinib or gefitinib. And so METMAB is an antibody to the MET oncogene. This is the design of the trial. This was a second or third line non-small cell lung cancer trial. Patients were randomized in a 1-to-1 fashion to either METMAB plus erlotinib or placebo plus erlotinib, and they were primarily looking at progression-free survival. They did perform immunohistochemistry on the available tumor samples to determine if the patients were MET positive by immunohistochemistry or MET negative. Now, when the trial results were reported, there was no difference in progression-free survival between the two groups. But what was significant about this study is the patients who were positive for MET appeared to have an improvement in progression-free survival when they were treated with the MET inhibitor combined with erlotinib versus erlotinib and placebo. And the hazard rate for progression-free survival was 0.53, which is a number we don't typically see in patients treated on non-small cell lung cancer trials. But more importantly, the hazard rate for improved survival favoring the METMAB arm was 0.37, and that is really unprecedented in non-small cell lung cancer. And that is in only the patients who had MET-positive tumors. Now, they looked at various subpopulations to discern if it was the MET positivity by immunohistochemistry, perhaps it was the MET positivity by FISH analysis, or perhaps other factors played a role, such as EGFR mutation status. So these numbers get pretty small, but I think we can see at least there are some trend lines. If patients were MET FISH positive, there did appear to be a slight improvement for patients who received the MET antibody. But if patients were FISH negative, they still appeared to have an improvement with the MET antibody as long as they were immunohistochemistry positive. So this upper panel suggests that the FISH status is not the key, but perhaps simply being immunohistochemistry positive. Now we look at EGFR mutation status, and this is a group of patients who are MET positive but had EGFR non-mutations versus MET positive, FISH negative, and EGFR non-mutations. And once again, the driver of this was MET positivity by immunohistochemistry, and it was not driven by EGFR mutation status or by MET FISH status either. This is a look at the side effects of the MET inhibitor, which you can see there is one particularly unique side effect, and that is peripheral edema, and that was more than double in the group of patients who received METMAB plus erlotinib versus placebo plus erlotinib. Now I'd like to turn our attention to this study, and this is called the EUROTAC trial. Just to give you a little bit of background about this trial, about 2 years ago, a group from Asia reported the results of a trial called IPASS. IPASS was a trial of Asian patients who had adenocarcinoma and were primarily never smokers. Those patients were randomized in the first-line setting to the EGFR inhibitor gefitinib versus carboplatin paclitaxel. That group reported no difference in survival in the Asian population, regardless if they got an EGFR inhibitor or if they got carboplatin and paclitaxel. Again, this is a group of never smokers with adenocarcinoma. They had a pre-planned subset analysis, though, looking at this never smoking group. They divided them by EGFR mutation status. It turns out about 60% of the patients had EGFR mutations and 40% did not. When you look specifically in the group of patients who were never smokers who had EGFR mutations, their progression-free survival was substantially better if they received gefitinib. And the converse was true. If they were never smokers but did not have EGFR mutations, the progression-free survival far favored the chemotherapy group. This was prospectively assessed in a second Asian study confirming those results. Those with EGFR mutations benefited from the EGFR inhibitor. Those who were EGFR wild type benefited with the chemotherapy. The EUROTAC trial is really replicating this data in a prospective fashion, but not in an Asian group of patients, but rather a European group of patients. And this is the design of the study. The patients were chemotherapy naive. This was first-line treatment. They all had an EGFR mutation, and they were randomized to platinum-based chemotherapy versus erlotinib. And this is the progression-free survival, significantly favoring the erlotinib group. So this data has now been replicated in a non-Asian population, which is something that's very important to do because the Asian population frequently has, the outcomes on the trials can differ sometimes from North American and European populations, and this may be due to pharmacogenomic issues or biologic characteristics of the tumor. When they looked at overall survival, there was no difference in overall survival, but this is probably attributed to crossover, whereby those patients who were randomized to the chemotherapy arm eventually were treated with erlotinib, and that occurred in the majority of patients, therefore blunting any difference that one might find in overall survival. This is the second study I'd like to look at looking at strategy, and it's called the PARAMOUNT study. This study was a phase 3 study assessing the role of maintenance pemetrexed in patients who had previously received cisplatin and pemetrexed as induction therapy. And the idea behind this is to see if we can improve progression-free survival by continuing pemetrexed after having already received pemetrexed as induction therapy. And this is the design of the study. Again, these patients were chemotherapy naive. They all received cisplatin and pemetrexed for 4 cycles of therapy. If they had not progressed, they were then randomized to either maintenance pemetrexed plus best supportive care versus placebo plus best supportive care. And again, the primary endpoint of this trial was progression-free survival. And indeed, the investigators met their primary endpoint. Those patients who continued on pemetrexed after the initial 4 cycles of cisplatin and pemetrexed had an improvement in progression-free survival compared to those who stopped their pemetrexed and went on placebo alone. Now, this type of result has been seen in other trials with other drugs, showing that if you prolong therapy with the same drugs in the first-line setting, you can improve progression-free survival. However, those studies using the same drugs in the maintenance setting as were given in the frontline setting have largely not shown an ability to improve overall survival. We have not seen the results of overall survival on this trial. We've only seen the results of progression-free survival and quality of life. And so the question remains, what is the relevance of an improvement in progression-free survival? Certainly, if one can demonstrate that your symptoms remain under better control or you have fewer complications from your cancer as a result of longer disease control, or if you have an improvement in other quality of life parameters, that this by itself would warrant the use of maintenance therapy, even if you weren't able to demonstrate an improvement in overall survival. Well, this quality of life analysis was performed on this trial. And if you looked at the very bottom of the slide, what you'll see is that there's no statistical difference in the quality of life scores between the 2 arms. And we do know that those patients who received maintenance pemetrexed did have more adverse events as a result of receiving pemetrexed. Most of these were not serious adverse events, but nevertheless, many of them were things like fatigue. There can be some low-grade nausea, occasional diarrhea, and sometimes rash. So this is the data that we have at this point, and I think it's too premature to utilize maintenance pemetrexed after having received induction pemetrexed as the first-line setting. And I believe this is my last slide. This was, I thought, a very intriguing study. I had mentioned earlier that patients who have EGFR mutations have a very high likelihood of responding to EGFR inhibitors, but invariably patients eventually progress. In those patients who progress, repeat biopsies have demonstrated at least two main mechanisms of resistance. One of them is called a T790 mutation, and the other I've already referred to, which is the MET amplification. The T790 mutation represents a change in the conformation of where the EGFR inhibitor binds against the tumor, and it doesn't allow it to bind where it had previously been binding before. One strategy to overcome resistance based upon this mechanism is to use what we call an irreversible EGFR inhibitor. The EGFR inhibitors that we use now, gefitinib and erlotinib, are reversible inhibitors. They bind to their site, they inhibit the tumor, but they also come off the site as well. The irreversible inhibitors bind and then don't release. So it shouldn't make any difference if you change the conformation of the binding site if the drug is already bound. So this is something that's been well demonstrated preclinically, that EGFR inhibitors that are irreversible are active in the T790 mutation cell lines. And there's nice preclinical evidence that shows when you combine one of these irreversible inhibitors, such as the drug afatinib, with an EGFR antibody, you can further overcome the resistance than just the irreversible inhibitor alone. So the investigators on abstract 7525 took a look at this. They had treated patients with EGFR tyrosine kinase inhibitors, and then the patients had progressed, and the patients were rebiopsied. All of the patients were then treated with afatinib, which is an irreversible EGFR inhibitor, combined with cetuximab, which is an EGFR antibody. They were all treated regardless of whether they had the T790 mutation or not. And what they reported was that more than half of the patients who did not have the T790 mutations were able to achieve a response with the utilization of these two drugs. And about a third of the patients who did have a T790 mutation were able to achieve a response with a combination of these two drugs. And this is very provocative because we know that patients who are treated with EGFR antibodies by themselves don't appear to have much activity in either of these patient populations. But if you combine the antibody with an irreversible inhibitor, it seems to be able to overcome resistance both through the T790 mechanism as well as other mechanisms that haven't been described at this point. I think this is very interesting data and will certainly lead to further study. So I'm going to end there, Jack, and hopefully we'll have some questions and be happy to field those.
We'll continue with the question and answer session in a later podcast. Thanks for listening, and thanks to our co-sponsor, Longevity Foundation, for helping to make the live program and these enduring podcast materials possible.